it's my honor to introduce Emily. Emily Haller is a nationally recognized expert in digestive health and medical nutrition therapy for gastrointestinal diseases. Emily currently serves as a lifestyle and culinary medicine coordinator at Trinity Health, where she integrates her GI nutrition expertise into innovative lifestyle and culinary medicine programming. She is passionate about empowering individuals to improve their digestive health through practical, personalized nutrition strategies rooted in whole food, plant-based eating. Previously, Emily worked in the Division of Gastroenterology and Hepatology at Michigan Medicine, where she provided individualized nutrition counseling to patients with complex GI disorders. During her time there, she co-founded and served as co-director of the annual GI nutrition training program for dietitians, Food the Main Course to Digestive Health. A dedicated educator and collaborator, Emily has co-authored book chapters and published articles in the field of GI nutrition. She holds a Master's of Science in Nutrition and Dietetics from Central Michigan University and a Bachelor of Science in Nutrition Science from Indiana University. Beyond her work in GI nutrition, Emily combines her love of food and science through endurance sports nutrition counseling, recipe development, and food photography, bridging the gap between clinical advice and everyday life. And with that, I'll pass it to you, Emily.
Thank you so much, Jocelyn. Thank you for the introduction and the opportunity to be here today. I am really excited to be here with all of you, dietitians, maybe some other healthcare providers, and talk about the art and science of nutrition in functional dyspepsia. So this is the journey that we are going on together today. My objectives are to define functional dyspepsia. We're going to talk about the subtypes through the lens of the Rome 4 criteria. We're going to talk about dietary patterns, specific triggers with evidence for and against them when it comes to symptom exacerbation or helping with symptoms. I'm going to outline a practical evidence-based nutrition care plan for functional dyspepsia, and then we're also going to be talking about behavioral and lifestyle strategies that complement our dietary interventions. So to begin, functional dyspepsia, or I'm going to refer to it as FD often throughout this talk. This is a very common disorder of gut-brain interaction, and it affects over 20% of the population. And we know it negatively impacts quality of life. This is well documented in the literature. And it is defined by symptoms referable to the gastroduodenal region, so upper gut, and that includes bothersome postprandial fullness, early satiety, epigastric pain, or epigastric burning in the absence of structural abnormalities. FD is further subdivided into two subtypes. So we have postprandial distress syndrome, PDS, that is characterized by that postprandial fullness, early satiety. And then we have epigastric pain syndrome, so EPS, characterized by epigastric pain and or burning. And these two syndromes can overlap. Of note is that the symptoms should have persisted in the last 3 months, with symptom onset at least 6 months before a formal diagnosis is made, and nausea and or vomiting can be present. Now, the question here that I have is, can we just talk about FD without addressing gastroparesis? And I would say at this point, I think not. And here we have two papers that just came out within this year. So we've got functional dyspepsia and gastroparesis. Are they distinct disorders, a spectrum of disease, or just one disease? That's on the left, and on the right, we have a guide to assessment, investigation, and management. And while our role as dietitians is, of course, not to diagnose our patients with any condition, I do think that you will all agree that it's important for us to be up to date with best practices as well as emerging evidence so we can best help our patients. So we've already defined FD, and we see that definition here on the left. Again, those bothersome symptoms with the exclusion of organic origin of symptoms being necessary. This often includes an upper GI endoscopy as per the Rome 4 criteria. And then next to this, in this center column here, we have the definition of gastroparesis. And the recent idiopathic gastroparesis consensus has identified nausea and vomiting as cardinal symptoms. Frequently coexisting symptoms are early satiety and postprandial fullness, right? And these are also cardinal symptoms of FD. Diagnosis of gastroparesis requires the presence of these symptoms, nausea and vomiting, alongside delayed gastric emptying, measured by a 4-hour gastric emptying test or a gastric emptying breath test. And the most common etiologies of gastroparesis are diabetes, idiopathic, followed by drug-induced and post-surgical. And then on the right-hand column, we see some other conditions to consider that physicians are going to be considering when a patient presents with these upper gut symptoms, whether it's rumination syndrome, cannabinoid hyperemesis syndrome, cyclic vomiting syndrome, chronic nausea and vomiting syndrome, and then other comorbid conditions that we often see in these patients, whether it's anxiety, depression, and or an eating disorder. And I think one thing to also highlight here is that gastric emptying can change over time, right? So a person's gastric emptying could be normal at one point in time, and then it could be delayed later, or it could be delayed and then normal later. And we see that in research that's looking at gastroparesis and functional dyspepsia patients or patient populations. So here I just wanted to briefly highlight the 2022 ACG clinical guideline for gastroparesis. And this is summarizing the perspectives on risk factors, diagnosis, management of gastroparesis in adults. And that includes diet. That's where we've got these nice little arrows pointing here. This is where we're coming into play. And you can see that diet is a first-line therapy for patients with gastroparesis, and dietary management of gastroparesis should include a small particle diet to increase the likelihood of symptom relief and enhance gastric emptying. And then a bit older are these 2017 ACG and CAG clinical guidelines for the management of dyspepsia. This is where this algorithm here is showing the evaluation and management of dyspepsia, and the other healthcare provider that's in this algorithm is mental health provider, right? So considering psychotherapy for these patients, we are not a part of this algorithm. However, that does not mean, right, we don't have a purpose with these patients. I know we're receiving referrals for these patients, whether it's from providers or patients or, asking to see a dietitian for help. This figure shows a proposed approach that physicians are being encouraged to use for functional dyspepsia or gastroparesis. When patients are presenting with these upper GI symptoms, the key idea is to start treatment based on the patient's main symptom without immediately ordering tests like gastric emptying studies. This was presented at DDW this year as a part of a functional dyspepsia talk that I was a part of, and one of the physicians presented this and talked about it, and saying that testing is reserved for alarm features or when symptoms don't improve, and even then results often don't predict symptom relief, meaning we know that the rate of gastric emptying does not correlate well with symptom severity. So somebody could have a normal gastric emptying study and have severe symptoms. As dietitians, it's helpful to understand this framework so we can align dietary strategies with symptom management rather than test results alone. All right, so kind of moving on to the nutrition aspect. Many patients with functional dyspepsia recognize meals as a major trigger for their symptoms. As a result, dietary changes are often one of the first-line strategies both patients and clinicians turn to. If we look at some available studies, they show us that up to 80% of those with functional dyspepsia report food avoidance. However, high quality evidence linking specific foods or nutrients directly to symptom onset remains limited. And we're going to talk more about this. And this has led to a wide variety of non-standardized empirical dietary recommendations. And we're going to look at the main ones today. While some individualized dietary adjustments may be helpful, right? Absolutely can be helpful. It is important to recognize that broad or exclusion diets are not always beneficial, and in fact, when excessive, and I feel like everybody in this meeting will agree with this, right? Excessive exclusion diets are going to have the opposite effect, right? They can be harmful and are not going to serve our patients. Public interest in the relationship between diet and dyspepsia is extremely high. A simple Google search this year yields over 1 million results. But much of the available information is anecdotal, not evidence-based, and, surprise, often conflicting. Many patients understandably turn to self-diagnosis and trial elimination diets based on personal experience and or online advice. However, this can become problematic if it leads to overly restricted eating patterns that are going to compromise their diet quality and, of course, put them at risk for nutrient deficiencies. Additionally, highly restrictive eating can reinforce hypervigilance and symptom anticipation, key mechanisms in the pathophysiology of functional dyspepsia. So this can ultimately perpetuate rather than alleviate symptoms. All right, so this image is coming from an article by America Now and colleagues, and it outlines 4 key areas in the dietary management of FD. So we've got specific foods, dietary patterns, eating behaviors, and herbal treatments. Each of these can influence symptoms either by triggering or suppressing them, and may also impact gut function, inflammation, and overall symptom severity. Despite these insights, we still don't have standardized dietary guidelines for FD. Most of the available evidence comes from observational studies, and the randomized controlled trials are few in this space. A 2018 meta-analysis found no clear consistent links between any specific food or drink and symptom onset. So while we don't have a definitive list of foods to avoid or recommend in people with FD, we do see some trends. So we're going to kind of go through this figure. Commonly reported triggers include, so if we're kind of thinking about specific foods up here, fatty foods, spicy foods, soft drinks, wheat products, caffeine, alcohol. And on the other hand, some foods like apples, rice, bread, olive oil, yogurt have been reported by patients to help alleviate symptoms. Dietary patterns matter. We know this as dietitians, right? This is our zone of genius. Western diets and ultra-processed foods are linked to more FD symptoms, while higher fruit and vegetable intake and a Mediterranean-style diet seem protective. And then we're going to talk a little bit more about the FODMAP diet later in this presentation. When it comes to eating behaviors and functional dyspepsia, the evidence is mixed and often inconsistent. So some studies show that regularly eating at least 3 main meals and several small snacks per day may help reduce symptoms, while skipping meals, specifically breakfast and lunch, and not dinner, which I found interesting, and then a regular meal timing, late night snacking, and faster eating speeds have been associated with higher symptom burden in some groups. However, when we read this paper, when we read the meta-analysis, the overall quality of evidence is low, and these associations are not consistently observed across all studies. With all of that said, I think it is a very reasonable suggestion to encourage the intake of regular, balanced meals, right, throughout the day. Have the patient try small, frequent meals and snacks. Let's make sure they're not skipping breakfast and lunch and backloading the end of their day with a big dinner and late night snacking, and then recognizing individual responses vary. That to me seems like a very reasonable intervention and place to start with our patients. And then we have information on, some herbal treatments that have demonstrated efficacy in FD, and we're going to look at that in a little bit as well. So even though there are not, standardized dietary guidelines for FD, these three goals, optimizing nutrition, minimizing symptoms, and supporting a positive relationship with food, are commonly prioritized in clinical practice. Of course, each patient may have their own dietary goals, which may align with ours or look completely different. So it's important to collaborate. As always, right? We want to deliver patient-centered care and tailor our approach to the patient that is sitting in front of us. This figure shows how the gut senses the presence and composition of food after we eat, which is a highly complex, highly coordinated process that drives communication between the gut and brain. There are three main types of sensory modalities in the GI tract. So we've got mechanosensitivity, chemosensitivity, and thermosensitivity. So mechanosensitivity is referring to how the stomach and intestines detect stretch or tension when food enters, right? So this is largely about volume. These receptors tell the brain kind of how full the stomach is. Chemosensitivity is how the small intestine detects nutrient composition, so protein, fat, carbohydrates, and that information helps regulate digestion as well as satiety signals. And then thermosensitivity, I would say, plays a smaller role, though, interestingly, cold meals may slow gastric emptying. And so, in simple terms, the stomach, right, one of its functions is to stretch and accommodate a meal, and it senses how much food is in there, while the small intestine senses what is in it. Both send feedback to the brain, and that helps, impact appetite and meal size. Now, when we look at, certain GI disorders, DGBIs like FD, several are thought to involve changes or disruptions in these normal sensory pathways. And so we kind of see like a breakdown of potential issues with this little red star, potential targets of upregulation or sensitization. So in people with FD, research shows that there can be enhanced nutrient sensing, especially with fats. When lipids enter the duodenum, they trigger an exaggerated release of cholecystokinin, or CCK. CCK is a hormone. It normally helps slow gastric emptying and signals fullness. But in FD, this over response can lead to altered gastric motor function and more postprandial symptoms like that early fullness, bloating, or discomfort after eating. Interestingly, there are studies that have found that blocking fat digestion with orlistat or blocking CCK receptors with a CCK receptor antagonist can reduce these symptoms, which supports the idea that this pathway is involved. We've also seen exaggerated release of other gut peptides after duodenal exposure to lipids in FD patients. So there's likely this heightened chemosensory or hormonal response contributing to symptoms. What is unclear still is that these same exaggerated responses, like, do they happen during a normal meal? Since many of these studies are using a direct nutrient infusion into the small intestine rather than like an oral feeding. So that's, kind of TBD. Many patients with FD, they have impaired gastric accommodation and or delayed gastric emptying. We've covered that, which helps explain why larger meals often exacerbate symptoms like early satiety, fullness, pain. High-fat meals tend to slow gastric emptying and promote fundic relaxation, both of which can worsen symptoms in FD. Spicy foods, I think, are interesting. So, there's research that show that it can be problematic, and then there's some research that show that actually it may be helpful. So, kind of one of the theories is acute intake may worsen symptoms in some via this TRPV1 activation, but regular exposure may actually have a desensitizing effect in others. Alcohol and caffeine have been shown to exacerbate symptoms, likely due to their ability to increase gastric acid secretion and impair gastric motility. And then emerging data based on a 6-food elimination diet and confocal laser endomicroscopic evaluation, so CLE, right, for short, of mucosal response. This is in real time where these food proteins are put in the small intestine, and we can see the doctors see these reactions. And there are some studies in both IBS and FD that suggest a role for duodenal allergic reaction in FD symptom generation, which is really interesting. We're going to talk a little bit more about this in a couple slides. I would say like implementation of a 6-food elimination diet for FD in clinical practice awaits larger clinical trials and experience in that area. Okay, so what about the low FODMAP diet? We know this is an evidence-based approach for IBS, irritable bowel syndrome, and emerging research suggests that it may also benefit people with functional dyspepsia. In a recent review on dietary approaches for DGBIs, TAC and colleagues concluded that for FD, only the low FODMAP diet had sufficient emerging evidence to be, considered or used in clinical practice today. The proposed mechanisms behind symptom improvement with a low FODMAP diet approach include, we can see those here on the screen, reduced fermentation and gas production, right? We know this, decreased duodenal distension. It can help lower visceral hypersensitivity and increased duodenal transepithelial electrical resistance, which may reflect enhanced mucosal integrity. So in a preliminary report, improvement of symptoms and duodenal barrier function was observed after 6 weeks on a low FODMAP diet in people with FD. And then when FODMAPs were reintroduced in a blinded fashion, symptoms reoccurred with, or I should say, especially with mannitol and the GOS group, so both at 29%, followed by fructans, and then sorbitol, fructose, and lactose to a lesser extent. We can see here on this image, we know that this is a 3-phase approach. We want it to be implemented with dietitian guidance to avoid unnecessary restriction and, ensure nutritional adequacy. And then a thing to, I would say, consider or think about, right, when we have somebody go on a low FODMAP diet is the food antigens that are in some of these foods that we're removing from the diet. So food antigens that are prevalent in IgE food allergy are being reduced. So for example, we are reducing dietary fructans, so wheat, galacto-oligosaccharides, we're potentially reducing some nuts, soy protein, we're limiting foods that are high in lactose, so various milk products, thus reducing milk protein, so casein and whey. And if these food antigens are responsible for GI symptoms in at least a subset of individuals with DGBI, which is what those studies on CLE are showing, symptom improvement may be due to reduced antigen intake and an immune threshold rather than just the fermentation aspect here. And so this is kind of like an atypical food allergy presentation. Mechanistic studies to determine whether non-FODMAP components in these foods and if they're implicated or not in symptom response are needed. And that's what a lot of the, I would say, most up-to-date review papers on the evidence of diet and DGBIs are kind of saying and highlighting. And that's really what this paper is about. This came out earlier this year, and it's titled "Why Are Disorders of Gut-Brain Interaction Often Food-Related? Duodenal eosinophils and mast cells, small intestinal bacteria, food allergy, and altered food intake in FD and IBS." So this figure is from that paper, and I would say it illustrates one of the most exciting areas of current research, and the idea that certain foods can trigger immune and microbiota changes in the small intestine that contribute to symptoms in both a subset of patients who have FD and IBS. Postprandial symptoms like early satiety, bloating, discomfort, right, can reflect small intestinal involvement. When foods high in fermentable carbohydrates or potential antigens like milk, wheat, soy are ingested, they can activate immune cells in the duodenum. So we see evidence of low-grade inflammation, eosinophil and mast cell activation, and increased mucosal permeability, along with shifts in the microbiota. Where'd my little pointer go? So certain bacteria like the streptococcus and histamine-producing Klebsiella, and these changes can amplify local inflammation and visceral sensitivity, contributing to symptom generation. Therapeutically, symptoms may improve then with interventions that target these mechanisms, and that's what this paper is outlining. So whether it's dietary modification, modulation of the microbiota, or blocking histamine receptors, and the authors suggest that similar to eosinophilic esophagitis, right? That's where we have a lot of data and use of that 6-food elimination diet. So similarly, like removing specific food antigens could provide, a symptom relief, symptom cure in a subset of patients with FD or IBS who have this atypical food-related immune response. And this concept really represents a potential paradigm shift. So not just, managing symptoms, but identifying and addressing immune, microbiota, food interactions at their root. So I think this is really interesting. I think there's going to be a lot more to come. I'm really excited to see what happens in like the next couple of years, next 5 years, what we're going to know, and kind of what the algorithm of treatment is going to look like for these patients. So we're learning what's happening in the duodenum, not just the colon. This appears to play a major role in symptoms for people with FD and IBS. Recent studies show the duodenal microbiota looks very different in these patients compared to healthy controls. Diet seems to be a player, key driver. That's not surprising. I'm sorry if I mispronounce this, but the author Safori and colleagues, they found that a diet low in dietary fiber and high in refined carbohydrates reduced the diversity of the duodenal microbiota. And this was associated with increased symptom burden in individuals with TGBIs. And then kind of coming back to the specific species, an interesting finding was the dominance of the streptococcus species in the duodenum. Higher levels of this bacteria are tied to worse symptoms in individuals with FD. Some work even suggests that certain streptococcus species may help digest wheat proteins, which would then expose the gut to more antigens and trigger that local immune activation, which could help explain why some people react to foods like wheat, right? Like this non-celiac wheat sensitivity when they don't have celiac. A little bit more about the duodenal microbiota and diet. So there's also evidence that certain dietary patterns can support gut barrier. And so in this case control study, patients with FD had altered microbiota, not just in the stool, but also in the oral cavity and the duodenum. And duodenal changes included low-grade inflammation and reduced expression of tight junction proteins, which means the intestinal barrier is impaired. Looking at those specific microbes again, this was one of the studies that supported FD patients. They had more streptococcus in the duodenum, which correlated with that barrier dysfunction and symptom severity. And then dietary pattern mattered here. So they found that higher protein, polyunsaturated fats, and valine were linked to better mucosal integrity, and then higher duodenal streptococcus was associated with lower carbohydrate intake. And then I just thinking about that, and then the what we just were talking about the fiber and refined carbs. I think it's important to note when we talk about carbs in these studies, we're not talking about the same thing across the board. The study that's linking low fiber and high refined carb intake to worse symptoms points to diets that are high in processed foods, lower in plant diversity, lower in prebiotics. Like it's low in those microbiota accessible carbohydrates that feed beneficial bacteria. And in this study that we're looking at, this recent study mentioning low carb intake being associated with greater symptoms, likely reflects reduced intake of complex carbs, those that support microbial diversity and integrity. So the takeaway, and I'm like preaching to the choir here, but I gotta say it's like that the quality matters of carbs. Not all carbs are bad. Diets rich in fiber, whole plant foods seem to be protective and support a healthier duodenal environment, where highly refined or restrictive diets may worsen it. And then this small cohort study out of Istanbul explored whether removing milk and dairy products could improve symptoms in FD. So participants were split into two groups. One eliminated milk and dairy under the guidance of a dietitian. We love to see it. And the other continued their usual diet. After just 1 month, both groups reported improvement, but the dairy-free group had significantly greater reduction in overall symptom scores and several individual GI symptom domains. So this suggests that for some patients, milk or dairy components, is it the lactose? Is it the milk proteins? Is it another immune active compound might contribute to symptom generation? However, it is important to note the study's limitations, that dietary intake beyond milk was not controlled and it also was not recorded. So other changes could have influenced the results. However, it still raises a valuable clinical point that, if a patient with FD reports postprandial discomfort or bloating after dairy, or they have a high dairy diet, that maybe a short structured elimination trial under dietitian supervision, it could be a reasonable approach to test their tolerance and see if this helps with symptoms. All right. Now, this study looked at the presence of feeding and eating disorder symptoms in patients presenting with gastroparesis or dyspepsia, and they found that over half, about 55%, had clinically significant FED symptoms. And RFID, avoidant restrictive food intake disorder, was the most common, affecting roughly 23 to 40% of patients. Around 12% had other restrictive eating disorders like anorexia nervosa. Importantly, the more severe the GI symptoms, the higher the likelihood of having these FED symptoms, so feeding and eating disorder symptoms. For us dietitians, this highlights the importance of screening patients with gastroparesis or dyspepsia for RFID, for avoidant or restrictive eating behaviors. Early identification can help guide behavioral and nutrition interventions that may improve GI symptoms, while also mislabeling somebody with, a feeding disorder when the eating patterns may actually be a response to their GI symptoms. So potential screeners or tools that could be used would be the NIAS, so the 9-item RFID screener, which consists of 9 questions that evaluates various aspects of eating behaviors. And then we have the SCOFF questionnaire as well. And this is a 5-question screening tool. Yeah, I would say designed to clarify suspicion that an eating disorder might exist rather than to make a diagnosis, and then taking a collaborative approach as always with other appropriate healthcare providers. And just kind of keeping this on our radar when we're working with patients, because we know that there's that big overlap between GI conditions and eating disorders or disordered eating. And then when it comes to the power of our beautiful brains and expectations, I like to think about and talk about placebo and nocebo responses. Both gastroparesis and FD have surprisingly high, I don't know, I should say surprisingly, they have high placebo rates, around 30 to 40%, meaning many patients report symptom improvement even without active treatment. A recent meta-analysis also found a 26% nocebo response rate in those with FD. So this is where patients on a placebo reported side effects like constipation, headache, or diarrhea. And these findings highlight, again, how much expectations, anxiety, and the therapeutic context can shape how patients experience symptoms. For us as dietitians, it reinforces that how we frame dietary changes or symptom discussions really matters. Our words can influence both perceived benefit and potential discomfort. So, for example, if we frame certain foods as bad or harmful, this can increase anxiety or hypervigilance around eating, which may actually then heighten GI discomfort. It is a vicious cycle. And then on the other hand, we can use reassuring, neutral, empowering language that can help reduce some of that fear or anxiety around eating and food and potentially improve tolerance. So, all of that to say, our communication shapes expectations, and expectations influence symptoms, especially in individuals who have DGBIs, where that brain gut axis plays a major role. So for an example, if I were to say to a patient comes in, we do a diet recall, like, oh, you need to avoid all high fat foods because they're going to worsen your symptoms. Like you have a diagnosis of functional dyspepsia or gastroparesis, right? That can create fear and lead to over restriction. But if I were to say, some people notice certain high fat foods can be harder to tolerate. Let's experiment together to see what works best for you. This can set a much calmer, collaborative tone. It's the same information presented in a different way, right? And it's going to have a different impact. So just kind of reframing like, oh, these foods, you might be more sensitive to, feels a little less absolute and less anxiety provoking. I am curious, if you kind of have some words or some phrases that you use or like to use in clinic when discussing elimination diets and trigger foods. I mean, drop it in the chat. I think we can all learn from each other. All right, now let's move on to some lifestyle aspects. So physical activity. Aerobic exercise has been shown to improve, or I should say promote, GI motility, regulate peristaltic motion, hence improving dyspepsia symptoms. Also, cardiovascular activity can just make us feel better, right? It causes the release of endorphins, which reduces stress and improves our mood. Exercise also increases muscle uptake of branched chain amino acids, which often compete with tryptophan for passage across the blood-brain barrier. And this increases tryptophan uptake in the brain, which raises serotonin levels, a key neurotransmitter for emotional processing and mood. Valoria and colleagues demonstrated that physical activity reduces symptoms such as abdominal bloating by increasing intestinal gas clearance. And then that same group previously demonstrated that physical activity improved gas transit and abdominal distension in healthy subjects, but not the perception of bloating. And then here I have on the slide is an interesting study that used moderate intensity aerobic exercise in patients with IBS. That it was a structured, like in-person walking program where these participants got at least 180 minutes per week. And after exercise, all participants, every single one of them, experienced significant improvements in both their IBS symptoms and their physical capacity. And so while this isn't, a functional dyspepsia talk, these are both disorders of gut-brain interaction. There's also an overlap between IBS and FD. So I felt like this is a nice thing to highlight here. And then we see there are just we know exercise is good for us. Like holistically, it's good for all the organs. It's good for gut health. It also has a positive effect on gut microbial diversity with regular exercise, potentially influencing the composition and function of the microbial communities in the gut, which I think is really interesting. And so we've got some research on aerobic exercise specifically in the FD population. So this study looked at the impact of moderate aerobic exercise on patients with FD. And, they highlighted that while conventional treatments like PPIs are commonly used, they don't always address the full spectrum of symptoms or improve quality of life. So in this RCT, patients were split into two groups. One received conventional treatment alone, and then the other added aerobic exercise, specifically 30 minutes per session, 5 times per week for 6 weeks. And then both groups were assessed on day one and at the end of 6 weeks using these various, kind of validated screeners or scales. And both groups showed improvement. But the exercise group had significantly better outcomes across all measures: symptom severity, mood, and overall discomfort. And I would say what is exciting here is that this data supports a lifestyle-based adjunct therapy that we, as dietitians, can help implement and engage our patients in conversations around movement. It reinforces the value of interdisciplinary care, where nutrition and movement are working together to improve GI health. And, it might also open up more opportunities for us to collaborate more closely with exercise specialists, especially if we don't feel comfortable asking or talking to our patients about exercise. But I think most of us do. And again, this wasn't any fancy regimen. This was 30 minutes of aerobic exercise. So what happens then when we combine two interventions that have demonstrated efficacy in functional dyspepsia? Well, this prospective RCT that came out of India, my cat's jumping on me if you guys can see, this is Soba Noodle. She's going to join our meeting. This study came out of India, and it set out to look at just that, diet and exercise. And it was conducted among patients where functional dyspepsia eligible patients were assigned in a 1-to-1 ratio to either the intervention group, which was a low FODMAP diet and regular aerobic exercise, along with conventional therapy, or the control group was the conventional therapy alone for 24 weeks. And so this intervention group was given a low FODMAP diet and an exercise plan. The exercise plan was consisting of 30 minutes of aerobic exercise per day, 5 days per week. So that matches the physical activity guidelines that we have for all Americans, right, to get to that 150 minutes of moderate intensity aerobic exercise per week, plus the conventional therapy, whereas the control group, again, they just stuck with the conventional therapy for that 12 weeks. After the 12 weeks, patients in the intervention group were instructed to gradually introduce the FODMAP. So they were on the elimination diet for 3 months, which is longer than what I would say we recommend or we do, but this is a study. And so then patients added that back in and monitored for worsening symptoms to help with adherence to the diet and exercise plan. Patients received alternate day reminder messages, which were tracked using a calendar. And then they used these, again, validated questionnaires to look at GI symptoms and analyze health-related quality of life at baseline, at 12 weeks, and then at 24 weeks at the end. So what did they find? Well, the combination of a low FODMAP diet and regular aerobic exercise reduced dyspeptic symptoms, especially epigastric discomfort, improved health-related quality of life, and was more effective than conventional therapy alone. So the findings from this randomized controlled trial demonstrate that, again, there's statistically significant reduction in these symptoms with lifestyle interventions compared to conventional therapy alone. And then this study is a great reminder that not all upper GI symptoms originate from the stomach, from the duodenum. This is in patients with functional dyspepsia and constipation, which is common. And they found that correcting dyssynergic defecation, essentially retraining the pelvic floor, led to over a 20% reduction in postprandial fullness, while a fiber supplement had no effect. So this just underscores the importance of assessing and addressing bowel function, pelvic floor coordination, even when symptoms appear to be upper GI. And I know we're not treating pelvic floor dysfunction, but we might be the person to see our patient who's been referred to testing and they're hesitant because they don't think it'll make a difference, or they got a referral to see a pelvic floor physical therapist and they're not sure if it's going to make a difference, when it very very may, and it likely will, I should say. All right. So another lifestyle factor we can think about in these patients is sleep. And this study looked at 355 patients with functional dyspepsia using validated questionnaires for sleep, GI symptoms, and mental health. And a striking 81% had poor sleep quality, and more than half met criteria for insomnia based on subjective assessment, highlighting this is a very common issue in this patient population. Patients with disturbed sleep had significantly worse quality of life and higher anxiety and depression scores, as well as more severe symptoms. When they analyzed predictors, 3 stood out: older age, which I don't think is surprising, because as we age, sleep can become more fragmented, kind of our sleep cycles change, as well as higher depression scores and greater FD symptom severity. So those were the 3 predictors. And one of the interesting discussions in this paper was, why sleep matters so much for these patients, because we know sleep deprivation, even in healthy people, has been shown to lower pain thresholds, meaning we become more sensitive to discomfort, visceral sensations, pain, when we're experiencing sleep deprivation. And sleep deprivation is a form of chronic stress. So in patients with FD, poor or fragmented sleep could heighten visceral sensitivity and make normal digestive processes feel uncomfortable or painful. And that is, contributing or creating to that vicious cycle: sleep disturbance, increased symptom perception, increased GI symptoms, maybe that interferes with sleep, and kind of reinforcing one another over time. And this helps explain why in this study, those with worse sleep also had higher symptom severity. So it's, again, a bi-directional relationship between sleep and gut discomfort. From a practical standpoint, it's a reminder to, talk about sleep, address sleep as part of a comprehensive care plan, recognizing that improving sleep may reduce that visceral hypersensitivity and symptom burden. And so I want to talk a little bit about insomnia and what that is, right? So it's defined as difficulty sleeping despite having enough time and opportunity to sleep. It is a treatable condition, and cognitive behavioral therapy for insomnia, CBTI, is the gold standard treatment. And research shows that CBTI improves sleep in 70 to 80% of people with insomnia. And it offers long-term benefits that often outperform sleep medications like sedatives. So, it's been shown to be effective for people dealing with obstructive sleep apnea, depression, anxiety, PTSD, chronic pain, perimenopause. It's been shown to help people with IBS, cancer survivorship, and people with a cancer diagnosis and in cancer survivorship, and so forth. And so it works by addressing both thoughts and behaviors. The cognitive component shifts negative thoughts and beliefs about sleep. The behavioral component focuses on building healthy sleep habits and breaking unhelpful patterns. Over time, as stress decreases, the body recalibrates and sleep becomes deeper and more restorative. And I just, again, this isn't to say we have to bring all of this up in the first visit, right? The diet, the exercise, the sleep, it is all, it's all important. And you as the clinician can kind of decide where to go with the patient. But if we're meeting with somebody, especially over time, and that we're looking for some more angles or some more areas to help in, this can be very helpful to patients. And then I should highlight that, it can be is often delivered by a therapist, somebody that's trained in this, in a one-to-one setting, at a group, on the phone, or a workshop. And then there's also apps that are out there that can be used, potentially in a really motivated patient, or if we don't have access to somebody, and you can find a provider using Psychology Today. So, how do we know the best route to take with our patients? Where are we going to start? As dietitians, we begin with a thorough nutrition assessment, right? We want to get a full picture of what's going on. And, we do our assessment, we gather all of this information, and then we collaborate with our patients to put together a good plan with them. Part of that nutrition assessment, is generally going to involve asking about supplements and understanding what people are taking, what they've tried, what works, what doesn't, etc. And then that brings me to herbal treatments. So I said I'm going to talk a little bit about that and highlight specifically supplements like ginger, peppermint caraway oil, and STW5 target key mechanisms in functional dyspepsia, impaired motility, visceral hypersensitivity, and inflammation, and these can complement dietary and behavioral therapy. So we've got studies that suggest ginger can help improve gastric motility, reduce bloating and nausea, which are hallmark symptoms of FD. Ginger is frequently recommended for GI issues and is also used to treat headaches and motion sickness. Doses vary across studies, but typically range from 1,000 to 1,500 milligrams per day in supplement form. And, we can also talk to our patients about trialing it as a tea, or, adding fresh ginger to meals and cooking with it in that way. Enteric-coated peppermint caraway oil, mouthful, appears to relax the GI tract, right? It has this anti-spasmodic effect and reduce dyspeptic symptoms like pain and cramping. So pooled data from 4 studies show that it significantly improved global FD symptoms with a number needed to treat of 3. And these can be taken before meals to maximize effectiveness. And then lastly, STW5 is a multi-herbal formula that has, shown some promise in improving gastric motility and helping with FD symptoms. Okay, so putting it all together, kind of coming back to that main article that we were talking about, and thinking about, inducers versus suppressants. If we did a nutrition assessment and we're working with a patient, I'm always thinking about diet expansion, because I feel like a lot of times when we meet patients, they've already taken a lot of things out of their diet, but maybe not. Maybe there are some things, if they're eating, on the go a lot of fast food, spicy foods, high fat food, we could have that conversation. We could think about some GI friendly foods, maybe to help them add back in. We can assess their diet for FODMAPs. If they have a really high FODMAP diet and we feel they're an appropriate candidate, we could go that route and see how it goes. And, when we see them for a return visit, if they are feeling better and we have them start reintroducing and kind of being mindful of like the wheat. Is it all wheat? Is it the fructan, right? Because we know we can do sourdough bread, which is going to have that gluten and some of those antigens. And we can think about completely dairy-free versus lactose-free. And then the common sense eating behaviors, of course, chewing well, trying to eat in a relaxed state, like reducing some anxiety around meals, not eating on the go, late night snacking, large meals, high sodium dinners can impact our sleep. And we talked about the importance of sleep. Also, kind of keynote on constipation, we've got several studies at this point in time that show kiwi supports or has efficacy with helping with constipation. There's also several studies that show 2 kiwi per day improves sleep quality. So that could be a helpful solution for a specific kind of patient. And then I would also consider ginger or peppermint and or a peppermint caraway oil supplement strategy to aid some of these other things that we're doing. And I generally would pick one of those supplements to start with versus, throwing it all on at the same time. I'm also a big fan of supplement holidays. If somebody's already taking a ton of supplements and it's not helping. Then when we're thinking about putting it all together in terms of lifestyle, we're going to encourage regular physical activity. We're going to talk, about sleep and sleep hygiene and stress modulation. We may need to refer out to, a GI psychologist and or a sleep specialist, depending on the patient and what they're dealing with. And that really wraps things up with how important it is to take a collaborative, multidisciplinary approach. We know patients benefit with integrated care. We had the mantra trial show that patients with functional dyspepsia receiving multidisciplinary care, including dietitians, psychologists, and gastroenterologists, had significantly better outcomes than those receiving standard gastroenterologist only care. And nearly half of the patients in the multidisciplinary group experienced a 50% reduction in symptoms compared to just 11% in standard care. So I wanted to then highlight some free culinary sources as my last informational slide. If your patients are having a hard time taking some of the information that you are giving them when it comes to preparing more meals at home and putting together ingredients that they like and they work that works for them, these are free resources. We love free resources. You could use these for yourself or again use with your patients. Starting with Cooking with Plants. This is a free monthly virtual series. It's a culinary class. It is presented by my team, so Trinity Health, Ann Arbor, Lifestyle Medicine. My colleague Kelly Wilson runs this. She does a fantastic job. You can scan this QR code and sign up, and you can either attend it live. It's the second Wednesday of every month, and if you can't attend it live, your patients can't attend it live, then they receive a recording. The videos are up on Vimeo and YouTube, and it's really accessible. The goal of it is to empower participants with skills and knowledge to add health promoting plant foods to daily meals. Switch is extremely well done as well. This teaches cooking skills tailored to individual health goals, skill levels, and food preferences. Old Ways is a food and nutrition nonprofit organization that provides info, resources, recipes to help people live healthier lives through cultural foods and cultural food traditions, like the Mediterranean diet, for example. And then lastly, this is a newer program that came out this year. This is done by the American College of Lifestyle Medicine. It's a culinary medicine program. It's free, and there are really well done videos as well as patient handouts that you can use in practice. So sometimes the why it's important to change different things is where we start with our patients, but the how can be hard if people don't have the culinary skills, and this is where I would say these resources come in. And that, friends, brings me to the end of my presentation.
Wow, thank you so much, Emily. That was fantastic. I learned a ton. I hope everyone else out there did as well. We've got some really good questions here, so we'll do just a few, though I know we are at the top of the hour. To start, we have a question from Laura. I'm curious whether you've seen any associations between the increasingly popular carnivore diets and onset worsening of functional dyspepsia.
Yeah, I mean, I feel like that diet worsens all symptoms. So yeah, yeah, constipation, functional dyspepsia. I mean, but then again, there's always these pockets and corners of the internet saying, "Oh, this healed my gut. It healed all my symptoms." I don't see that in clinic though. I see a lot more problems with that type of dietary pattern.
Got it. Thank you.
Bad
Here,
for the gut, bad for the heart.
from Rita, we have a question. Any info about resistant starch as a potential trigger?
Sorry, can you say that again?
Any info about resistant starch as a potential trigger?
I have not come across that in anything that I read for preparing for this talk or for DDW earlier this year. So I don't know. I don't think so. Yeah.
Thanks. Here from Beth, we have a question. Can you describe the difference between functional dyspepsia and indigestion? She finds they're often used interchangeably.
Yeah, I think that's I to try to get like clear about a patient's symptoms, like if you're asking, like if a patient's asking you like, oh, do I have this or into I guess okay, let me back up. So I would think about the definition of FD, right? So if somebody is experiencing postprandial fullness, early satiety, and or pain, right, and these are bothersome, and they've been evaluated by a doctor because they do have to have like a structural abnormality out of the way or like ruled out, then it's functional dyspepsia. I think some people use that word indigestion to like describe their symptoms. Like I'm having indigestion. And that like, don't we all have indigestion every now and then? Oops, let me get out of here. I was trying to find something. My team is now messaging me because it's 101. So and that's okay. I can still stay on. It was just got a message that popped up. So yeah, I guess it probably depends on like the chronicity of symptoms, like how often somebody is experiencing a symptom. But there's definitely overlap there. Does that make sense?
For me, yes, thank you. I hope for everyone else out there as well. Here, this will be our last question. We have Mary asking, how does obesity complicate the symptoms of functional dyspepsia, especially when it occurs with increased gastric pain?
I mean, abdominal obesity most certainly can increase the risk for acid reflux and GERD. I'm not sure if it's going to complicate functional dyspepsia per se. That was also not something that I came across a lot in most of the papers that I've read in reviews. So, I mean, if we're talking about like what is causing, functional dyspepsia from like a hypervisceral sensitivity standpoint, that brain gut axis, it is a DGBI. We see different the stomach's ability to accommodate a full meal and empty, right? That overlap between GP and FD, and then like the duodenal changes. I feel like those things are that can happen in any body size, and I wouldn't necessarily say that like obesity is a risk factor for that. I would think more about like lifestyle and like what a person is eating, right? So if they have a Western dietary pattern, that is more likely to influence our microbiome, from the duodenum to the colon. And so, and there's an association between like the Western diet and body size. So there, that relationship matters, but I don't think that, obesity complicates functional dyspepsia or a person's like likelihood to respond to diet therapies, getting better sleep, exercise. Like the interventions are the interventions, regardless of somebody's weight and their likelihood to respond. I didn't see any like data to show that somebody in a certain BMI category is less likely to respond to any of the things that we talked about today.
Thank you so much, Emily. Yeah, very complicated, but great answer. So that concludes our webinar. Thank you so much for coming on to share your expertise.